So for those of you who don't know what Lynch syndrome is, it affects an estimated 175,000 people in the UK and is the most common cause of inherited endometrial and colorectal cancer. It leads to 1,100 colorectal cancers a year in the UK and is responsible for 3% of all colorectal and endometrial. Typically, the tumours will show an absence of one or more of 4 proteins that are related to Lynch syndrome, and I'll explain a little bit more about that. But it can also cause multiple other cancers, including gastric, small bowel, urinary tract, biliary tract, and brain, as well as skin, pancreatic, and prostate cancers. It's an autosomal dominant condition, which means that if somebody has the condition, there is a 50% chance that their children will also inherit it. And it can be inherited from either side of the family, so from either mothers or fathers. The condition causes an increased risk of cancer, which actually ranges from 10 to 57% of colorectal cancer and up to 49% risk of endometrial cancer. We talk about Lynch syndrome as one condition, but we actually know now that it's really more like 4 different conditions. The genes are very specific in the cancer risks that they cause. We know that MLH1 causes the highest risk of colorectal cancer at 57% in men and 22% of upper GI cancer in men as well, while MSH2 causes a 24% risk of prostate cancer, which is one of the cancers we didn't originally think was linked to Lynch syndrome. We also know that MSH2 causes significant risks for women with a 49% risk of endometrial and a 17% risk of ovarian, while the genes MSH6 and PMS2 have much lower risks. So although we would say somebody with these genes has Lynch syndrome, the reality is that their risk of cancer is much lower and the implications in terms of screening are much less significant. So in terms of the management for this condition, we would arrange colonoscopies every 2 years for people with Lynch syndrome, starting at either the age of 25 or 35. We also know that treating people with aspirin lowers the risk of cancer by 50%. So if you know someone has Lynch syndrome, you can decrease the risk of cancer very simply by giving them aspirin. We also know that H. pylori is a very significant risk factor for gastric cancer, and again, detecting and treating this can lower the risk by 50%. So another very easy intervention. For women who are unaffected and over the age of 40, they may consider having their womb removed and, depending on the gene, their ovaries, again to remove this risk of cancer. And for men, leading on from the prostate project, we know that they can have prostate screening with PSA testing, or there is a study known as IMPACT looking at the detection of prostate cancer. Leanne, who is coming to speak next, will tell you more about PGD, but this is pre-implantation genetic diagnosis, and it's a type of IVF that is aimed to prevent the next generation from inheriting the condition. So by establishing embryos, you basically extract a woman's eggs, fertilize them with her partner's sperm, and then grow them for a few days, and you can then test these embryos for the gene alteration and then lead to a pregnancy that is unaffected. So this is a very helpful technique for families. The other big thing about Lynch syndrome is it impacts the treatment of cancer. So if somebody has a colorectal cancer that's linked to Lynch syndrome, they would consider a subtotal colectomy rather than a segmental resection. And that's because the risk of another primary is high enough to consider more extensive surgery. Obviously, that's not an easy decision, but it's something that the patient and the surgeon would discuss together. We also know, as other speakers have talked about, the impact of medication targeted based on inherited factors. So immunotherapy is incredibly helpful for both endometrial and colorectal cancer, and it has been shown to be effective in between 46 to 100% of metastatic endometrial cancers. So these are patients that have metastatic cancer that have very limited other options, and immunotherapy has shown that it can put them in remission up to 100% of the time. So that is incredibly significant for families. We know that 1 in 350 people have Lynch syndrome, but 95% of people don't know they have the condition. So I've just shown you the management and the impact of knowing someone has Lynch syndrome. We can reduce their risk of cancer by 50%. We can target their treatment very significantly and prolong their life even when they're affected with cancer. But if they don't know they've got Lynch syndrome, we can't do any of these things. We also know that even when people have Lynch syndrome, historically they haven't always had the management they should have had. So the project that we're working on is aiming to change all of that. And it lines up very nicely with the NHS long-term plans, which is to identify all cancer, well, 75% ideally, of cancers at stage 1 to 2 as soon as possible, but certainly by 2028. The way that we do that is by testing every endometrial and colorectal tumour for Lynch syndrome. So that's done predominantly by immunohistochemistry, but also by microsatellite instability. Essentially, anybody diagnosed with colorectal or endometrial cancer is now screened for Lynch syndrome. But that wasn't the case, and that's why we've had a 2-year project to try and implement this. So once people have had this testing, if they have proficient mismatch repair, that means they probably don't have Lynch syndrome. In genetics, we don't give absolutes. It's always most likely, probably, the risk is. So if somebody has proficient, it's less likely. If someone has deficient mismatch repair, then there are a couple of reasons that can happen. 15% of colorectal cancer and up to 30% of endometrial cancer show this anyway. So sometimes we have to do further tests to differentiate whether it's real Lynch syndrome or it's something that's happened by chance. But the bottom line is, we get to a point where germline testing is indicated. So if somebody needs germline testing because they've got cancer and they've been screened for Lynch syndrome, we want to test them as soon as possible. So this should happen at MDT, as soon as the MDT knows that this is a possibility. There are different patterns on immunohistochemistry. If you see absence of MSH2 and 6, it's more likely to be inherited. But if it's MLH1, you need to do further testing, which is methylation. The important points to know, at this point, a family history questionnaire is not mandatory. So we're basing all further testing on our screening. It is helpful to know whether people have cancer in the family, but it's not necessary. We certainly don't want to delay the further testing. And we have patient leaflets available for this cohort of people, so the ones that have been screened and may or may not have Lynch syndrome. This is just summarising the pathway, which is essentially everybody's tested, every tumour is tested for Lynch syndrome. Depending on the pattern, they may be offered germline testing, and they should be discussed at MDM, multidisciplinary team meetings. When germline testing is offered, historically it's been done in genetic centres, in our genetic services. We've got quite a backlog of patients. It takes a long time for people to be seen in genetics, and we really don't want barriers between people and genetic testing and the ability to implement better management. So there's now this massive push for mainstreaming, which I'm sure you'll hear a lot about today. Mainstreaming is when genetic testing, genetic services aren't really the gatekeepers anymore. So the testing is done by the MDTs, by oncologists, surgeons, or CNSs. So it's done right at the point of diagnosis, and more people have access to testing. Once we have identified a Lynch carrier, they're then referred to our new system known as Lynch Syndrome Expert Hubs, which is another project that's been derived from... Oh, sorry, I'm just seeing somebody motion to me at the back. So we have the Lynch Syndrome Hubs, which ensure that the correct management and cascade testing occurs. So in our geography, we have 2 hubs. We have one hub at Cambridge, which covers the east of England, and we have one network across East Midlands. So the purpose of our Lynch syndrome networks are to ensure that the carriers get the best management, so that they are told about aspirin, they are told about H. pylori. We have the oncologists at the moment tell us about immunotherapy, but very soon I'm sure there'll be other options. So the cutting edge technology is available to all Lynch carriers, not just the ones that are lucky enough perhaps to see somebody who's an expert in the field. It's also a repository of information and expertise. So in genetics, we like to have complicated cases, complicated situations. When that happens, these people are discussed at the hubs. We also will have, and I'm quite excited about this, a multidisciplinary clinic for all carriers. So what that means is that anyone with Lynch syndrome can come and talk to a surgeon, an oncologist, a gynecologist, genetics, anybody who they need for their treatment, all on the same day. So they're not having 5, 6 different appointments at different times, different places. It'll all be there on the same day, and everybody's able to come and get that information. So the next step in the pathway is we've had the project, we've established that we've screened everyone for Lynch syndrome. We've hopefully identified as many Lynch syndrome carriers as we can. We've ensured that their management of cancer is targeted based on their inherited condition, and we've referred them to the new Lynch hubs to make sure that they're managed in the best way possible, and also to make sure that their management in terms of colonoscopies happens automatically. Historically, people may not have had colonoscopies every 2 years, which is a really bad risk. We now have safety processes in place to make sure that they do get their colonoscopies and that they are appropriately referred. Once all of that has happened, you then have a person whose relatives have a 50% risk of having the condition themselves. So their brothers, sisters and children, if they're adult children, may want to have genetic testing. We therefore do what we call cascade testing. And cascade testing only happens in genetic services, and the reason for that is that it's quite an involved process. We would sit down with someone, ask them about their medical history, check their family history, and discuss with them whether genetic testing is the right thing for them. Do they want to know about this risk? And if they do, is now the right time? For example, if they're about to sit finals, we're not going to tell them that they have this risk. We would suggest that they come back after they've completed their exams. If they're about to get married, maybe now is not the best time. We talk through all their personal things going on in their lives and the timing of genetic testing, as well as the implications. One of the things that we talk about is the fact that if you have 2 sisters, there's a 50% chance that for each of them. So you could have one sister with the genetic condition and one without. And we talk a lot about something called survivor guilt, which is when someone actually gets good news, but their sibling doesn't. And actually they feel quite bad about that, or they can do. And we want to support them, explain that that's very normal, and talk through all of those implications, and ensure that when the family's gone through genetic testing, they're as well supported as they can be. We also refer for psychosocial support if needed. People often have difficulty understanding and processing this information, whether they have the gene alteration or whether they don't. And we need to be able to detect when people may have underlying risk factors for psychological problems, at which point we refer on for further support, either before or after testing. We also signpost them to relevant resources. The bottom line, of course, is when people are ready and appropriately counselled, we arrange genetic testing, and therefore hopefully identify people with Lynch syndrome, feeding them back into the management, making sure that we lower their risk of cancer, and if it does happen, that we pick it up at an earlier stage. So what have we done so far? I've told you about 2 projects, 1, universal screening for all Lynch syndrome, and 2, setting up the Lynch syndrome hub. In order to do this, we have identified colorectal and endometrial champions in every MDT across our geography, so across East of England and East Midlands. That means there's somebody in every MDT that should be thinking about Lynch syndrome, we hope. We have also ensured that MMR testing is in place across all the trusts. It wasn't initially, so now we have predominantly IHC, but some trusts do MSI. We've seen that the screening has gone from 21% for endometrial cancer in 2019 to 93%. So that's a massive increase, and if you think about the implications for those patients and their family, that's a massive change. We've also seen colorectal cancer's gone from 51% to 93%. Colorectal cancer's had a bit of a head start. We've been doing this since 2017, whereas endometrial since 2020. But again, it's a big change. We've also seen that the reflex testing for methylation, so this is where it gets complicated. If your IHC is abnormal, I've talked about the fact that it could be sporadic or it could be inherited, you need to do methylation to determine which of those it is. And that has taken months, which is really unhelpful when you're trying to work this out as quickly as possible. That testing has now moved to Cambridge, which is our GLH, so the hub for our region, and we're hoping to see a much quicker turnaround time. We're also seeing mainstreaming in a lot of trusts, and we provide a lot of training nationally, locally, in MDTs. We've basically annoyed the MDTs so much that they think about Lynch syndrome when they see us, and that they've done a lot of external training as well. So every genetics service is now able, in our region, has uploaded historic data and is prospectively uploading patient data to the NDRS, so that colonoscopies will be nationally organised every 2 years. The national screening should start imminently, should have started in May, but there's a small delay, and the expert hubs have been set up across the region. What's next is we have our patient launch for the East Midlands network in September. Sally from MK and I are doing stock-taking meetings with every trust to check exactly where they are and make sure they're up to date. We're doing sustainability planning, and we're looking at pilots to extend to other tumour sites. I would now like to introduce Leanne Barrett, who is a brand marketing manager for Next. She's also a mother, and she has Lynch syndrome, and will be talking much more eloquently, I'm sure, than I have been. Thank you, Leanne.